Hey, I'm Dr. Carter, and today I want to tell you about a patient I will never forget. He was 58 years old, active, not overweight, no chest pain, no shortness of breath. He had his annual checkup 3 months before. Cholesterol was normal, blood pressure was fine. The doctor told him he was in great shape. 6 weeks later, he had a massive heart attack. Stories like his are not rare, they are common, and they happen because modern medicine has been measuring the wrong thing and missing the real thread for decades. That's what this channel is for. The science your doctor doesn't always have time to explain, the answers behind the numbers. Subscribe now and turn on the bell. New videos every week, because what you're about to hear might be the most important thing you hear about your heart this year. Here is a number that should stop you cold. Nearly half of all people who have a heart attack have cholesterol levels that are considered normal, not borderline, not slightly elevated, normal. They passed their blood tests. Their doctors gave them a clean bill of health, and then their heart stopped. How is that possible? Because the story medicine has been telling about cholesterol and heart disease for the last 50 years is incomplete. Not wrong, incomplete. And the part that's missing is the part that is actually killing people. That missing piece has a name: inflammation. Chronic low-grade inflammation, the same silent process we have discussed in previous videos, is now understood by leading cardiovascular researchers to be the primary driver that turns cholesterol from a passenger into a weapon. Without inflammation, cholesterol circulates harmlessly. With inflammation, it becomes the trigger for heart attacks and strokes. And here is the most dangerous part of all this. Inflammation has no symptoms. You cannot feel it. It does not cause pain. It does not show up on a standard cholesterol panel, and it is not something most doctors test for in routine checkups. Even though a landmark study published in the New England Journal of Medicine followed 28,000 women for 30 years and found that inflammatory markers predicted cardiovascular events more powerfully than LDL cholesterol alone. Today I am going to show you what is actually happening inside your arteries after 50. The 8 silent signs that your cardiovascular inflammation is elevated right now, and the exact tests and strategies that research supports for addressing the real risk, not just the number on your cholesterol panel. And sign number 5 is the one that shocks people most, because it appears somewhere nobody connects to heart disease. Stay until the end, because the final section will change how you think about your heart health for the rest of your life. Let's get into it. Before we get to the signs, I need to establish the science that most doctors know but most patients never hear, because it reframes everything about how you understand your cardiovascular risk. The conventional model of heart disease goes like this. High LDL cholesterol builds up in the arteries. The buildup narrows the arteries. Narrowed arteries cause heart attacks and strokes. Lower the LDL with diet, with statins, with lifestyle, and you reduce the risk. That model is not wrong, but it is dangerously incomplete. Here is what the research now shows. Cholesterol does not simply pile up in arteries, the way rust accumulates in a pipe. The process requires a trigger, and that trigger is inflammation. When the inner lining of an artery, the endothelium, is inflamed and damaged, it becomes sticky and permeable. LDL cholesterol particles penetrate the damaged wall. The immune system recognizes the trapped cholesterol as a foreign invader and launches an attack. White blood cells flood in, foam cells form, plaque develops, and the plaque that forms in an inflamed arterial environment is unstable, soft, vulnerable to rupture, and it is a ruptured plaque, not a gradual narrowing, that causes most fatal heart attacks. This means that a person with moderately elevated LDL but low inflammation may be at far less risk than a person with normal LDL but high chronic inflammation. The cholesterol is not the ignition. The inflammation is. This is not a fringe theory. A landmark 30-year study published in the New England Journal of Medicine found that high-sensitivity CRP, the primary blood marker of systemic inflammation, had a hazard ratio of 1.70 for cardiovascular events. LDL cholesterol had a hazard ratio of 1.36. Inflammation was the stronger predictor. And in the fall of 2025, the American College of Cardiology formally recommended that clinicians routinely screen patients for inflammatory proteins alongside cholesterol. The science has arrived at the mainstream. The clinical practice is catching up, but most routine checkups still measure cholesterol and miss inflammation entirely, which is exactly why knowing these signs matters so much. Here is what cardiovascular inflammation looks like in the body after 50. Sign number 1. High triglycerides combined with low HDL, the metabolic signature of vascular inflammation. Most people focus on LDL, but the combination that most consistently signals dangerous cardiovascular inflammation is not LDL at all. It is elevated triglycerides alongside low HDL cholesterol. This pattern, high triglycerides, low HDL, is the metabolic fingerprint of insulin resistance and visceral fat accumulation, both of which drive systemic vascular inflammation directly. When triglycerides are above 150 milligrams per deciliter and HDL is below 40 in men or 50 in women, this combination indicates that the metabolic environment is actively inflaming blood vessels, independent of what the LDL number shows. Research consistently shows that this triglyceride to HDL ratio is a more powerful predictor of cardiovascular events than LDL alone in adults over 50. Yet most people leave their doctor's office knowing only whether their LDL is good or bad. Know your triglycerides, know your HDL, and know their ratio. Divide triglycerides by HDL. A ratio above 3.0 indicates significant metabolic and vascular inflammatory risk. The next sign is one that millions of adults are experiencing daily and attributing to something else entirely. Sign number 2, elevated resting heart rate, above 80 beats per minute consistently. A resting heart rate above 80 beats per minute, measured consistently, not after exertion or stress, is one of the most overlooked markers of chronic cardiovascular inflammation in adults over 50. Here is the mechanism. Chronic inflammation activates the sympathetic nervous system, the fight or flight branch, and keeps it in a state of low-grade activation. This sustained sympathetic tone elevates resting heart rate. The heart works harder than it should at rest, placing additional mechanical stress on already inflamed arterial walls. Research published in the European Heart Journal shows that adults with resting heart rates consistently above 80 beats per minute have significantly higher rates of cardiovascular mortality, independent of fitness level, blood pressure, and cholesterol. The association is particularly strong in adults over 50. The target resting heart rate for cardiovascular health after 50 is below 70 beats per minute. If yours is consistently above 80, measured first thing in the morning before getting out of bed, this is a clinically meaningful signal worth investigating. Sign number 3, persistent gum disease or bleeding gums. This is one that most people dismiss entirely as a dental issue. But the connection between periodontal disease and cardiovascular inflammation is one of the most well-established and most consistently overlooked associations in all of medicine. The bacteria responsible for periodontal disease, particularly Porphyromonas gingivalis, directly enter the bloodstream through inflamed gum tissue. Once in circulation, they trigger systemic inflammatory responses and have been found in atherosclerotic plaques in coronary arteries. Multiple large studies show that adults with moderate to severe gum disease have significantly elevated cardiovascular risk, not because gum disease causes heart disease through some indirect pathway, but because both conditions share the same underlying inflammatory driver and the oral bacteria directly worsen vascular inflammation. If your gums bleed when you brush, if you have been told you have periodontal disease, or if you notice persistent bad breath that does not respond to dental hygiene, these are not trivial cosmetic issues. They are systemic inflammatory signals that directly affect your cardiovascular risk profile. Sign number 4. Elevated waist circumference, even at normal body weight. A person can be at a completely normal body weight and carry dangerous levels of visceral fat concentrated in the abdominal region. And visceral fat is not metabolically inert. It is one of the most potent drivers of cardiovascular inflammation in the human body. Visceral fat, the deep abdominal fat that surrounds the organs, produces inflammatory cytokines including interleukin-6, tumor necrosis factor, alpha, and resistin. These compounds enter the portal circulation and travel directly to the liver, where they drive systemic inflammatory pathways that destabilize arterial plaques and promote endothelial dysfunction. The measurement is simple: waist circumference above 40 inches in men and above 35 inches in women, regardless of total body weight or BMI, indicates clinically significant visceral fat accumulation and associated vascular inflammatory risk. This is why two people with identical cholesterol panels can have radically different cardiovascular risk profiles, because one carries their weight in the abdomen and one does not. And it is why waist circumference is a more useful cardiovascular screening tool than body weight alone. Sign number 5. Worsening sleep quality, particularly non-restorative sleep after 50. This is the sign that surprises people most, because nobody thinks of poor sleep as a cardiovascular risk factor. But the research is unambiguous. During deep, slow-wave sleep, the body actively repairs endothelial cells, the inner lining of blood vessels that, when damaged, becomes the site of inflammatory plaque formation. It also suppresses inflammatory cytokines, resets cortisol rhythms, and clears metabolic waste from tissues throughout the body. When sleep quality deteriorates, as it reliably does after 50, this repair and suppression cycle is compromised. Endothelial repair slows. Inflammatory cytokines remain elevated for longer overnight, and the cardiovascular system accumulates damage faster than it can recover. A study published in the European Heart Journal found that adults who slept less than 6 hours per night had a 48% higher risk of developing or dying from coronary heart disease compared to those who slept 7 to 8 hours. Not 48% higher LDL, 48% higher risk of actual coronary events. If you wake unrefreshed despite adequate hours in bed, if you feel like your sleep no longer restores you the way it once did, this is not simply a quality of life issue, it is a cardiovascular risk factor that deserves the same clinical attention as your blood pressure reading. Sign number 6. Elevated fasting blood sugar, even in the pre-diabetic range. Most adults receive their fasting glucose result and hear one of two things, normal or diabetic. The vast middle ground, fasting glucose between 100 and 125 milligrams per deciliter, classified as pre-diabetes, is frequently dismissed as something to watch. But research is unambiguous that even mildly elevated fasting blood sugar in the pre-diabetic range produces direct vascular inflammation. Elevated glucose glycates attaches to proteins in the arterial wall, producing advanced glycation end products called AGS. These AGS trigger inflammatory responses in the endothelium, stiffen arterial walls, and directly promote the formation of unstable atherosclerotic plaque. In adults over 50, where insulin sensitivity has naturally declined and post-meal glucose spikes are larger and more prolonged than in younger adults, even borderline fasting glucose represents years of cumulative endothelial damage that does not show up on a cholesterol panel. If your fasting glucose is above 100, or if you have never had a post-meal glucose test, this is one of the most actionable cardiovascular risk markers available. A continuous glucose monitor worn for 2 weeks provides more clinically useful cardiovascular risk information than a standard annual cholesterol panel. Sign number 7. Chronic low-grade pain, joint pain, muscle aches, or generalized inflammatory discomfort. The inflammatory processes that damage arterial walls do not stay confined to the cardiovascular system. They are systemic, and in many adults over 50, the same inflammatory mediators that are silently damaging blood vessels are also producing low-grade musculoskeletal pain, joint aches, muscle soreness, a generalized physical heaviness that most people attribute to aging, elevated interleukin-6, tumor necrosis factor alpha, and C-reactive protein, the primary inflammatory markers associated with cardiovascular risk, are also the mediators of musculoskeletal pain and fatigue. They do not operate in separate compartments. They are the same systemic inflammatory cascade expressing itself through multiple organ systems simultaneously. This means that persistent, unexplained musculoskeletal discomfort in adults over 50, pain that has no specific structural explanation that comes and goes without injury, may be a systemic inflammatory signal with direct cardiovascular implications. If chronic low-grade pain has become part of your baseline experience, something you manage rather than investigate, it is worth asking whether the inflammation driving that pain is also affecting your arterial walls. Sign number 8. High sensitivity, CRP above 1.0 on a blood test, even with normal cholesterol. This final sign is the one that gives numbers to everything else on this list, and it is the test most doctors never order during a routine checkup. High sensitivity C-reactive protein, hsCRP, is the most clinically validated blood marker of systemic vascular inflammation available. Unlike standard CRP, which only detects significant acute inflammation, high-sensitivity CRP detects the low-grade chronic inflammation that silently damages arteries over years and decades. The landmark Jupiter trial, one of the most important cardiovascular studies of the last 20 years, enrolled 17,802 adults with normal LDL cholesterol but elevated hsCRP above 2.0 milligrams per liter. These were people who would have been told by their doctors that their cardiovascular risk was low. The trial showed that these apparently low-risk individuals had significant cardiovascular event rates, and that addressing their inflammation dramatically reduced that risk. The reference ranges that matter. hsCRP below 1.0 indicates low cardiovascular inflammatory risk. Between 1.0 and 3.0 indicates moderate risk. Above 3.0 indicates high risk, regardless of what the LDL number shows. This single test costs less than $20 at most laboratories. It can be ordered alongside a standard lipid panel, and it provides information about cardiovascular risk that a cholesterol test simply cannot. If you have never had your hsCRP measured, ask for it at your next appointment. By name: high sensitivity C-reactive protein. If you recognize 3 or more of these signs, what comes next is exactly what you need. Now for the part that matters most: what to do with this information, both in terms of testing and in terms of the specific strategies that research supports for reducing cardiovascular inflammation after 50. First, get the right tests. At your next medical appointment, request the following alongside your standard lipid panel: high sensitivity CRP, hsCRP. This is the inflammation marker. ApoB, apolipoprotein B, which measures the actual number of LDL particles rather than just their cholesterol content, and is a more accurate predictor of cardiovascular risk than LDL-C alone. Fasting insulin, not just fasting glucose, which reveals insulin resistance years before blood sugar becomes elevated. And lipoprotein A, LPA, a genetic cardiovascular risk factor present in approximately 20% of the population that is almost never tested but significantly elevates inflammatory cardiovascular risk. These 4 tests, combined with a standard lipid panel, give a cardiovascular risk picture that a cholesterol test alone cannot provide. Second, omega-3 fatty acids, 2 to 4 grams of EPA and DHA daily. Omega-3 fatty acids are among the most extensively researched anti-inflammatory interventions for cardiovascular health. The REDUCE-IT trial showed that high-dose EPA, 4 grams daily, reduced cardiovascular events by 25% in high-risk adults beyond what statins alone achieved. The mechanism is direct anti-inflammatory action on arterial walls, reducing endothelial inflammation, stabilizing existing plaques, and lowering triglycerides simultaneously. The form matters. EPA and DHA from fish oil or algae-based sources at therapeutic doses of 2 to 4 grams daily, not the 300 milligram capsule most people take. If you are on blood thinners, discuss with your physician before starting high-dose omega-3. Third, extra virgin olive oil, 2 to 4 tablespoons daily, raw. Oleocanthal, the active compound in high-quality extra virgin olive oil, inhibits the same COX-1 and COX-2 inflammatory enzymes as ibuprofen without the gastrointestinal side effects. The PREDEEMED trial, one of the largest cardiovascular nutrition trials ever conducted, showed that adults assigned to a Mediterranean diet supplemented with extra virgin olive oil had a 30% reduction in major cardiovascular events over 5 years. 2 to 4 tablespoons daily, drizzled raw over food after cooking. Heat degrades oleocanthal. The anti-inflammatory effect requires unheated oil. Fourth, resistance training, 2 to 3 sessions per week. Resistance training, not cardiovascular exercise alone, produces a specific anti-inflammatory effect through the release of myokines from contracting muscle tissue. Myokines, particularly interleukin-6 released by exercising muscle, which has paradoxically anti-inflammatory effects when produced through exercise, directly suppress the inflammatory pathways that drive vascular damage. Research consistently shows that adults over 50 who engage in regular resistance training have significantly lower hsCRP levels and better arterial compliance than those who do only cardiovascular exercise. 2 to 3 sessions per week of bodyweight training, resistance bands, or light weights is sufficient to produce this effect. Fifth, sleep as a cardiovascular intervention. Given what we discussed in sign number 5, treat sleep with the same clinical seriousness as blood pressure management. 7 to 8 hours, consistent sleep and wake times, a dark, cool room, no screens 60 minutes before bed. This is not lifestyle advice. It is evidence-based cardiovascular risk reduction with an effect size comparable to many pharmaceutical interventions. Important note: this information does not replace medical care. If you have established cardiovascular disease, are taking statins or blood thinners, or have elevated cardiac risk factors, bring this protocol to your physician as a complement to your existing treatment. Do not modify prescribed cardiovascular medications based on this video without medical supervision. Today you heard the story that half of all heart attack victims could tell, if they had known what to look for before it happened. Normal cholesterol, no symptoms, and a silent inflammatory process destroying arterial walls from the inside out. You saw the 8 signs of elevated cardiovascular inflammation, from the triglyceride to HDL ratio and elevated resting heart rate to the bleeding gums in sign number 3 that most people treat as a dental problem, to the non-restorative sleep in sign number 5 that is quietly preventing the endothelial repair your arteries need every night, to the HSCRP number in sign number 8 that costs $20 and tells you more about your cardiovascular risk than your cholesterol panel ever could, and you saw the 5 strategies that research supports for addressing the real risk, the right tests to request, omega-3 at therapeutic doses, extra virgin olive oil, resistance training, and sleep as a cardiovascular intervention. Here is what I want to leave you with today. A normal cholesterol test is not a guarantee. It is a partial picture, and after 50, partial pictures are not enough. Ask better questions, request better tests, and know that the most dangerous cardiovascular risk is the one that produces no warning at all, until it does. If this video changed how you think about your heart health, please hit the like button. It helps this channel grow and reach more people who need this information before it's too late. Subscribe and turn on the bell so you don't miss the next videos. Share this with someone over 50 you care about, someone who was told their cholesterol is fine and assumed that meant their heart was safe. This video might be the most important thing they see this year. And leave a comment right now. Tell me, have you ever had your HSCRP tested? And did your doctor ever explain to you the difference between cholesterol and inflammation as cardiovascular risk factors? I read every comment personally, and your question could become our next video. I'm Dr. Carter, I'm here, and I'll see you in the next video.